Listen now to a talk Richard Conti had with Dr. Brian Ference, Associate Professor of Medicine at Wayne State University School of Medicine in Detroit, Michigan. They cover a naturally randomized trial comparing the effects of long-term exposure to lower LDL cholesterol, lower systolic blood pressure, or both, on the risk of cardiovascular disease.
Brian, first of all, I think you've got to explain to me and to the audience, what the heck do you mean by a naturally randomized trial?
Well, first, Dr. Conti, thank you very much for inviting me. It's a pleasure to be here. And I think that that's an important question, because what the naturally randomized trial, we use that term specifically in order to convey a message to the readers that we can introduce a randomization scheme into observational epidemiologic research and structure the study in exactly the same way we would structure a randomized trial, so it's easier to interpret, it's more intuitive to the reader. What it does specifically is it takes genetic polymorphisms. Perhaps the easiest way to explain...
Which you measure genetic polymorphisms.
So in this particular study, we created a score of 46 different polymorphisms associated with lower LDL cholesterol, and a separate systolic blood pressure genetic score consisting of 33 polymorphisms associated with lower systolic blood pressure. We then use those scores as instruments to naturally randomize people to higher or lower LDL cholesterol, higher or lower systolic blood pressure, or both, in a factorial design, exactly the way we would in a randomized trial.
How did you lower the blood pressure, and how did you lower the LDL?
We didn't actually intervene to lower it, but rather the scores randomized people to higher or lower levels. Now, this is referred to as the concept of Mendelian randomization, and perhaps the easiest way to explain the concept of Mendelian randomization is by way of analogy with a randomized trial. So there are numerous polymorphisms, for example, that are associated with lower LDL cholesterol, and each of those polymorphisms are inherited approximately randomly at the time of conception, in the process sometimes referred to as Mendelian randomization. So inheriting an allele associated with lower LDL is analogous to being randomly allocated to a LDL lowering therapy, while inheriting the other allele is analogous to being randomly allocated to usual care. If allocation really is random, then the only difference will be at their LDL level, and we can follow people forward to get an unconfounded estimate of the causal effect of LDL in a manner analogous to a long-term randomized trial.
Let me see if I got this straight here. All randomized trials that I know of have entry criteria and exclusion criteria. Were any entry and exclusion criteria in this methodology?
We did. We had a much broader sense. So that's an important question, because there's a fundamental difference between the persons enrolled in a naturally randomized trial or a Mendelian randomization study and those enrolled in a randomized trial. Unfortunately, those enrolled in a randomized trial, for convenience, are those that have advanced atherosclerotic disease, because the expectation is they will have the greatest number of events in the shortest period of time to minimize that sample size. And attempts to lower LDL or lower blood pressure in that population may have minimal impact, or at least less than optimal impact, because of their advanced atherosclerotic and arteriosclerotic burdens. By contrast, this approach of the Mendelian randomization, or naturally randomized trials, contemplates keeping blood pressure and cholesterol lower beginning much earlier in the atherosclerotic disease process, and therefore it examines explicitly what could happen if we began to intervene on risk factors, not necessarily pharmacologically, but with lifestyle factors and other methods, much earlier in the atherosclerotic disease process.
What would happen if you tried to prevent risk factors from happening?
Or at least control them in some way.
Prevention, I personally don't believe we prevent anything. I think we delay it. But if you really want to prevent an event, a cardiovascular event, it's got to start in childhood. You've got to prevent the risk factors from evolving.
Right. I think this is sort of exactly what we try to assess in this study. I'm not so sure it necessarily has to be childhood. I think in childhood is the perfect time to begin introducing people to healthy lifestyles. However, whether or not we aggressively seek to set targets or lower risk factors that young is hard to say. I think for LDL cholesterol, certainly it's a little bit different because it's fairly stable over the life course. But blood pressure is slightly different. Blood pressure remains stable into the 20s and 30s. And then once it reaches a certain point, it hits an inflection point and then begins to rise linearly with age. The key is, can we identify when it begins to rise and prevent the rise in blood pressure with age? And this study addresses that.
So what did you find?
Just by way of background, the purpose of the study was specifically to evaluate the causal effect of combined exposure to both lower LDL and lower systolic blood pressure on the risk of cardiovascular disease. And the reason why we sought to address this topic is because previous observational studies have suggested that those persons who can maintain ideal risk factor profiles throughout the whole of their lifetime have very low lifetime risk of cardiovascular disease. Unfortunately, fewer than 5% of the population can maintain ideal risk factors. By contrast, previous Mendelian randomization studies from our group and others have suggested that both LDL and systolic blood pressure are not only causally related to cardiovascular disease, but they have a cumulative effect over time. And as a result of that, that would suggest a simple strategy that promotes long-term exposure to the combination of both lower LDL and lower systolic blood pressure may be a very effective strategy for preventing cardiovascular disease. Unfortunately, the causal effect of exposure to both lower LDL and lower systolic blood pressure on events is unknown. And that uncertainty was recently increased after the report of the landmark HOPE-3 trial. As you know, HOPE-3 reported that the combination of lipid-lowering therapy plus a modest blood pressure-lowering regimen didn't reduce cardiovascular events significantly more than the lipid-lowering arm alone. And that has caused some people to question the synergy between LDL and blood pressure on the risk of cardiovascular disease, particularly among persons without hypertension. So we specifically wanted to determine the causal effect of combined exposure to lower LDL and lower blood pressure.
Couple of questions I have at this point. What was the average age of patients in this trial?
Yeah.
That's one. And secondly, what did you consider hypertension and hyperlipidemia?
That's right. So we didn't make, if I may, I'd like to address the latter question first. We didn't really define hyperlipidemia or hypertension as a criterion. In fact, I would go so far as to suggest that the way we treat hypertension at the moment is slightly backward. Rather than letting arteriosclerotic injury advance over multiple years to the point where the person develops a blood pressure of 150 or 160 and then argue about how low we should lower it, we should probably begin to think about the notion of preventing the age-related rise, and this study gets to that. But with regard to your first question, the average age was 60.7 years. The average LDL was about 3.4 millimoles, or 128 milligrams per deciliter, and the average blood pressure was about 126 millimeters of mercury.
So it's relatively low blood pressure.
Yeah, relatively normal levels, and that's the point of the study, is that even among persons with apparently normal levels, we want to contemplate whether or not maintaining low levels, not necessarily pharmacologically, but through healthy lifestyles, maintaining low levels and preventing the rise can...
Let me just give you a little anecdote here. When I was in medical school, which was in the last century, the normal blood pressure was considered 100 plus your age.
FDR walked around with a blood pressure, a systolic blood pressure of 240 during his fourth term. And
He died of a stroke, too.
Yeah, hemorrhagic stroke,
Right.
unfortunately.
Well, okay, that's just an aside. Obviously,
sorry.
those days are over.
So with regard to the trial, we used those LDL genetic scores and the systolic blood pressure scores to naturally randomize people into four groups: a reference group, a group with lower LDL, a group with lower systolic blood pressure, or a group with both. And what we found is that the combination of exposure to both lower LDL and lower systolic blood pressure was associated with a significantly greater benefit than lower LDL alone or lower systolic blood pressure alone. And in fact, the effects were independent, multiplicative, and cumulative over time. And because the effects were multiplicative and cumulative, the effect of a 1 millimole per liter lower LDL plus 10 millimeters lower systolic blood pressure over a prolonged period of time was associated with an 86.1% reduction in the risk of cardiovascular events.
1 millimole.
Right, I'm sorry, 38.67 milligrams
so
per
it's
deciliter.
close to 40
Right,
milliequivalents per liter.
And that effect was quite consistent across multiple different composite cardiovascular outcomes and the individual components of the composite, including MI and coronary heart disease death, with an 84% reduction in coronary heart disease death, which translated into a smaller but still significant and robust 36% reduction in all-cause mortality. And in addition to that, the effect seemed to be consistent across all of the subgroups we studied.
So the take-home message for our listeners, the way I understand it, is number one, blood pressure and LDL both lower risk. The combination lowers it a little bit better than individually. And then there is a cumulative effect over time that's persistent. Anything else?
I would say that last point is the salient point. If we'd like to prevent cardiovascular disease, we might have to have at it slightly earlier than we do at the moment.
Sounds good to me. We'll leave it at that. Thank you very much for coming to ACCEL, Brian, and I appreciate what you had to say.
It was my pleasure. Thank you very much for inviting me.